Thank you very much for the kind introduction and for the opportunity to address these complicated issues and indeed controversial issues. So I am a trialist, as you've heard, and I'm just wondering whether this is a trap. Hopefully not, or hopefully it's an opportunity to discuss many difficult issues surrounding trials. We do trials because Leonardo da Vinci said 500 years ago that opinions deceive us all. They're strongly held. Bad things are done on the basis of opinions. In medicine as well, and we try to find ways to go beyond opinions. So let's give you an example of what opinions are like. It's a historical and beautiful story of George Washington dying in his home. He was feeling unwell after being out for the day, and he had a throat irritation and couldn't do the usual reading of his documents. After retiring for the night, he was feeling very uncomfortable, and his wife was very concerned and wanted to send for help. But she'd had a cold, so he said, just don't go out there, you might get sick. So she sent for a helper, Tobias Lear, and he found him to have difficulty breathing. And so they sent somebody to get help from Dr. Craig. But in the meanwhile, at the request of the patient, the first medical intervention of the time was performed, which is vivisection. So while waiting for the doctor, about half a pint of blood was taken, even though, as usual, the wife, being a very sensible individual, raised concern about the usefulness of such an intervention. And of course, the throat was sore, and a variety of other interventions that at the time felt to be beneficial were given to him, and they almost killed him right away, as he convulsed and nearly suffocated, as he probably had epiglottitis. The morning progressed, and the president was feeling unwell, and a second opinion was sought. This second opinion was well respected, and he came and he noted that the major problem was in the throat, and he decided that the right thing to do was to produce a blister at the back of the throat to balance the fluids in the throat and in the patient. And in addition, the first doctor ordered a second intervention, which was that of a potion of vinegar and sage tea for gargling. And then they sent for a third physician because the ailment was very serious, and an enema was now administered in the hope that this would improve the situation. And then Washington was bled again for an additional time, and it looks like it was about 1 liter of blood that was removed from the president. A conference of physicians was held, and clearly the interventions had failed, and so the next step was the induction of vomiting, but this didn't really help very much. And despite all of this, the condition worsened, and the president, quite along the lines of his personality, thanked everybody for their service. But yet they persisted, and they did blisters and cataplasms, which is kind of the poultice application, and things continued to fail, and George Washington died. So has anything changed? Are we any different from the treatment George Washington received? Well, some of you might think, of course we are. But let me just go back now to 1978. This is the textbook that I used to prepare for my final year exam, Harrison's Textbook of Internal Medicine, a huge tome of 2,000 pages that contained the truth as we understood it then. And of course, if you had a heart attack, you had to rest in bed, preferably for 6 weeks. You really didn't want to strain, so your toilet privileges were restricted, and you were given laxatives so that it would be soft stool. But you wouldn't be allowed to get out of bed to pass it. Beta blockers weren't given because they were dangerous for you. Ectopic beats were dangerous. The extra beats of the heart had to be suppressed with a drug called lignocaine, which was given by continuous infusion. There was a belief that was a plaque or a potential clot in your vessel that should not be touched, so no one should attempt an angiography for 6 weeks in people with a heart attack. And of course, there was not enough oxygen going to the heart, so everybody had to be on oxygen to maximize the oxygen delivery to the heart. And this was what I learned in medical school. That's how I passed my exam. Now, as most of you would know, all of it is gone. All of it is now the subject of derision, ridicule in the medical field. So, let's go to today now. Are we any better in critical care medicine? Well, I'm sorry to tell you that over the last 20 years, at the turn of the century, we've practiced according to a variety of beliefs that we've had, opinions and early limited evidence that we should make the glucose normal, that we should give albumin to protect the tissues from edema. We should particularly give it to people with traumatic brain injury because it would protect them from cerebral edema. That because high intracranial pressure might kill you, we should treat it aggressively, potentially by removing the skull in patients that have diffuse brain injury. So, and then the trialists like me arrived and they said, well, are you really sure? Why don't we randomize lots and lots of people and try to find out? And this is glucose control. The conventional approach, which was not to pursue intensive glucose control, as was promoted by multiple guidelines, by multiple august societies at the time, was associated with almost a 3% increased risk in mortality. We estimate that by doing this trial, we saved about 65,000 lives in North America and Western Europe. Because increased intracranial pressure might be dangerous to you, we should remove it in every possible, decrease in every possible way. And we should do so by doing a craniectomy, by removing the vault of the skull so that the brain has the ability to decompress. Now, this is pretty serious stuff. I mean, we're making fun of the enemas, but this is pretty serious stuff. So in diffuse brain injury, doing a craniectomy works. It's fantastic. Look at the reduction in intracranial pressure with that intervention. It's dramatic. It's wonderful. The problem is, as you see there in the red arrow, that the score of function of cerebral recovery of these patients is significantly worse in those that have had a decompressive craniectomy. Possibly because as we take the vault of the skull off and the brain moves forward, the axons just snap broken and never recover. So, we believe that when people have a low blood pressure, particularly children that are shocked, we should give them lots of fluid to support the blood pressure and resuscitate them. And that is the right thing to do. And that's been, in fact, it still is, supported by some guidelines by the American Society of Critical Care Medicine. And so the white man's medicine was taken to Africa to save African children with severe sepsis by the administration of large fluid doses and the attempt to improve their quality. The problem is that if you give saline or albumin as fluid resuscitation, you actually double the mortality of these children. So once again, trials demonstrate that clinical medicine practiced according to beliefs of the time is incredibly dangerous. One of the things that dominated the world for about 20 years is the use of colloidal fluids, particularly commercially prepared colloidal fluids, so-called starch fluids, because the theory and the animal experimentation suggested that these fluids would stop the fluid from going from the intravascular compartment to the tissues. But the trials had not really been done. They were commercialized, sold, and given to literally millions of people on the opinion of treating clinicians. Now looking back and thinking the mashed potatoes going intravenously to people is a great idea seems totally insane. But then it was done, and that's only about 15 years ago. And so the trials were done. These are people with septic shock, randomized to have Ringer's acetate, which is a crystalloid solution, versus the starch solution. And of course, the starch solution was shown to increase mortality in these patients. Other studies were done by us here in Australia in people admitted to ICU here in Australia, and we were able to show that the administration of starch was injurious to the kidney, with a significant increase in the degree of renal injury, but also the need for acute dialysis in critically ill patients. And yet, there is a trial in the Journal of the American Medical Association in people having major surgery just a few months ago, a few weeks ago. The answer is still the same. The answer is still the same. It's just extraordinary that this stuff goes on. So why does all this happen? Why is it that doctors continue to do these crazy things that trials subsequently show to be crazy? Are doctors particularly stupid? Well, sometimes. However, to be fair to them, they have to make decisions. And so their world is binary. There is this, whatever you do, even if you don't do anything, you're making a decision. And they can't tolerate the thought that at a deep level, they still don't know what we're doing because the biology of the human body is extraordinarily complex. And so you have this incredible phenomenon where random care is delivered that cannot provide any learning experience because it's just one patient and you cannot come to any specific conclusion. And it is regularly associated with problems. So doctors have to live with the illusion of knowledge. And that is important to their practice, but it's not helpful to patients. And then doctors are also afflicted by another thing, which psychologists have described very clearly. It's called overclaiming bias. So what's overclaiming bias? People, not just doctors, lawyers, I'm sure as well, overclaim to the extent that they perceive to have expertise in a particular area. Multiple psychological experiments have shown that. So people regularly say they know stuff that actually doesn't exist or could not be known. And if they believe themselves to be experts in a particular area, like medicine or the law, they will have much greater self-perceived knowledge and they will overclaim. And telling them that they might be overclaiming them doesn't stop them. And so, for example, if you do some experiments and for about half an hour you keep on telling them, gee, you know a lot of geography. Oh my gosh, you must be a real expert in geography. And of course, Samarkand is the capital of France, right? And they will say, oh yeah, I know that. That's a fact. It's a given. It's fascinating what the human psychology is like. So is it possible then that doctors practice rational astrology? What is rational astrology? Rational astrology was practiced with George Washington. It's a belief that people have that something is right, that it works, irrespective of whether there is evidence that it is empirically shown to be true. They're kind of indifferent to the empirical data that may or may not be present. Now, sometimes they might actually be right. As William Osler said, 50% of what we do for our patients is right. 50% of what we do is wrong. We just don't know which one is which. But that's how it all works. And rational astrologies are all over the place. Your breakfast is the most important meal of the day. What are the randomized controlled trials? What's the outcome measure? Measured how? How do we know? And so on and so forth. And of course, all human endeavors, politics, the law, education, are rational astrologies because they lack empirical randomized evidence. And Mark Twain said it very nicely, it's not what you don't know that gets you into trouble, it's what you know for sure that it just ain't so. So what should we do? Are we more ethical in pursuing random, or are we more ethical in pursuing randomized medicine? The reality is that every day doctors make decisions with good intentions, I hope, and they don't get consent from the patient. They make decisions without clear evidence, empirical, randomized, robust, without evidence of benefit. They make those decisions. They don't ask for consent to make random decisions. And yet, they are given this extraordinary privilege to do that. The trialists are never given. So when the trialists want to randomize patients to interventions so that we can learn something and benefit potentially those patients, but also many other patients in the future, they are subjected to an extraordinary amount of regulations and rules as though we were about to do something incredibly evil. So random evidence, random practice. Random implies that there is no need for consent. No conclusion can ever be drawn from random medicine. Getting consent to look at the data is never applied. People will look at your clinical data in clinical practice every day. Decisions are often by one person and one person only, who believes in a particular therapy, like the doctors treating George Washington. And of course, the outcomes, well, we don't know what they are. They're transformed, seen from different points of view, and always presented as successful in order to maintain the doctor's self-esteem. Randomized medicine, on the other hand, requires consent, but then conclusions can be drawn. Consent has to be applied for to obtain data that are actually available to 5,000 people in the hospital every day just by pushing a button. And yet, this is a process where every decision has been made by a group of multiple doctors, multiple people, ethics committees, where there's been an extraordinary amount of surveillance and monitoring. And of course, the outcome is monitored forward. So let me say that the logical conclusions are that for widely and randomly applied therapies that we do every day within the boundaries of current practice, randomized critical care medicine is ethically superior. If random medicine can be applied with the implied waiver of consent, then randomized medicine for sure should logically be treated in the same way. Patients who survive can be informed after the fact and given the choice perhaps to allow follow-up if they wish or do not wish. The constructs around the practice of clinical critical care medicine and the conduct of randomized trials in that specialty are the wrong way around and are ethically suboptimal. Thank you very much.
Well, a few disclaimers. Firstly, the more I know, the less I know. Lawyers who belong to ethics committees are just ethics committee members. They're not experts. They're just there to occasionally point the right direction in relation to the legal provisions of the Medical Treatment and Planning Act, but probably no more. And since I've been ensconced in Google Scholar for 2 or 3 days reading around the literature, about the literature on consent in emergency settings, I realise that I know nothing and would gratefully be guided by people of the expertise of the person I've just heard to provide the clinical and ethical rationale for the support for emergency clinical trials. But I do have a long-standing interest in the interplay of history and philosophy of science, the development of evidence-based medicine, and the interplay between ethics, medicine and the law. I have done my time under the old Guardianship Act. I was the Vice President in charge of the Guardianship Act under the Guardianship list of VCAT under the old days, when in the late 1990s and early 2000s there was no ability of the tribunal of a family to consent to enrolment in urgent medical research, and I had to devise a 24/7 oral consent system because the tribunal had to consent to the enrolment of each patient in any clinical trial. And so for 6 years, myself and a colleague, John Billings, answered the phone wherever we were in the world for 24/7 to give consent to the enrolment of these people in clinical trials. And my final disclaimer is, so I know a little bit about how desirable it is for the Act to get it right. I'm not sure that this incarnation gets it righter from the point of view of my previous speaker, but that's perhaps for another discussion. And finally, my last disclaimer is that I'm married to a serial trial investigator, and so I've watched from close by, the quest for the ischemic penumbra, the fate of most international stroke-related drug trials, the emergence of clot retrieval and TPA, and the ongoing battle for more stroke and ambulance funding. So by disposition, at least, I have some inclination as to the importance of clinical trials in an emergency setting and some appreciation for the difficulties that they have to address. But as I said, I haven't yet got my head around all the ethical issues which perhaps surround our Act. But what I'm going to do briefly today is for 5 minutes just remind you of the consent provisions that surround emergency research and non-emergency research in the Medical Treatment and Planning Act. Then going to emphasise just one aspect that troubles me, which has been the importance of a broad recruitment of participants in clinical trials and the importance of not excluding patients for reasons other than defined eligibility criteria. And the third thing is to address the way in which we in ethics committees inform ourselves adequately about the ethical considerations that are relevant to, for example, multi-centre clinical trials. Now, just taking you to the non-emergency medical treatment provisions, you're probably all familiar with them, but if the proposed participant in a non-emergency medical research lacks capacity to consent to participate but is likely to recover capacity within a reasonable time, the research intervention can't proceed. You have to wait for them to recover and get their consent. If they lack capacity to consent to participate, you have to make reasonable efforts to find out whether they have an appointed advanced care directive or a medical treatment decision maker. If there's an appointed medical treatment decision maker, then their consent has to be sought under Section 77. If there is no appointed medical treatment decision maker, then the other people who may fill that role and whose consent must be sought are in descending order of priority: a guardian, a spouse, a domestic partner, primary carer, adult child, parent, adult sibling, and that's provided for in Section 55. If there isn't any advanced care directive and there is no medical treatment decision maker who's appointed or who can fit a person who's in that category of family, etc., the research intervention can still take place provided the project has ethics committee approval under Section 75 and Section 76, and that Sections 80 and 81 are complied with. That is, the researcher believes on reasonable grounds that participation would not be against their values, which can be in a values directive or be inferred from their lives or the preferences they've expressed, their well-being, and that the research procedure does not involve more than a risk to them than other medical treatment and is based on valid scientific hypotheses. And where a person is enrolled in a project under these provisions, the researcher has to keep looking to identify and contact a medical treatment decision maker to seek consent to the continuation of the procedure, assuming, of course, that the trial doesn't involve just one intervention and the administration of a drug on the one occasion. And Section 81 provides that within 30 days of the research procedure being administered, the researcher is to prepare a certificate covering the matters set out in the section, place that certificate in the patient's clinical records, and send a copy of the certificate to the Office of the Public Advocate. The Act is silent on whether and from whom consent is to be sought to continue, that is, to ongoing clinical follow-up and data collection. I suppose you could infer that the same hierarchy applies. Now, turning to consent to emergency medical research, Section 53 provides that as long as the practitioner is not aware of a refusal by the person to have the procedure, either through an instructional directive or an informal refusal of treatment, an emergency research procedure can be administered to a person without their consent or authorisation from a medical treatment decision maker, provided the procedure is necessary as a matter of urgency to save the person's life, prevent serious damage to the person's health, or prevent pain and suffering or continued pain or distress. In that case, there's no need to search for an advanced care directive. Now, clearly, most trials that we deal with, emergency research trials, require a combination of these processes because the first intervention is one which will be the emergency intervention, and that first intervention can and should occur without consent under Section 53. And I say should because A, if the situation is truly urgent, there will be no time to talk to relatives, etc. But B, even if there is, that time will be short, infused with drama and distress, and those circumstances are inconsistent with the rational, unhurried consideration implicit in an informed consent process. This does not mean that relatives should not be told what's going on. Rather, they can be informed that the participant is receiving best care available and is also part of a trial which has been approved by an ethics committee. Once the first intervention has been administered without consent, if the participant remains incapable of giving consent and time is no longer of the essence, the consent of a medical treatment decision maker can be sought under Section 80 and certification completed under Section 81 for the remaining interventions involved in the trial and for the collection and use of data from the trial. Of course, if at any time the participant recovers decision-making capacity, they must be asked for their consent to ongoing participation, although again the Act is silent on this. But please remember that no one can ever be asked for retrospective consent. Now, the second thing I wanted to turn to is really the importance for research of maintaining an inclusive set of trial participants. Let me begin with some propositions that I've gleaned from my research and the experience that I've conducted in preparation just for today. I know it's a tip of the iceberg, and I know that if I'm wrong, the real researchers in the room will correct me. But there seems to be very strong evidence that patients treated in hospitals with a strong clinical trials research focus do better than patients with the same conditions that are treated elsewhere. Secondly, whilst the evidence may not yet be conclusive, there is growing evidence that clinical trials have a positive rather than negative effect on the outcome of participants. Positive results for clinical trial participants have been reported in relation to breast cancer research, in a meta-analysis concerning participation in clinical trials in obstetrics and gynecology, to name but a few. That study went as far in 2017 as to conclude that the benefits were caused by the advanced oversight involved in their care in a trial, the fact that they received above and beyond usual care, which was guaranteed by ethics and governance approval, as well as safety monitoring and protocol compliance. In the area of cancer research, especially a clinical system that enrolls patients at a higher rate produces treatment advances at a faster rate with concurrent increases in survival and mortality reduction in the cancer population. Therefore, enrolment in clinical trials is foundational and lies at the heart of the clinical trial endeavour. So for this reason, the identification of specific barriers to trial enrolment and efforts to remove such barriers has itself become a critical research objective for cancer research and for other investigators. The literature is full of research calling for investigators to seek to enrol participants from various minority groups, women, young adults and the elderly, so as to improve the generalisability of the data collected in various trials. And the literature has identified three major obstacles to the participation of patients in clinical trials. And one study identified those as being three in nature, in number. One, clinician behaviour in excluding patients for reasons other than defined eligibility criteria. Two, concerned about increasing time requirements in the documentation process. And three, suboptimal communication with patients. I just want to raise two of those because they relate to things that we've been noticing in our HREC. The first is this, and they're related. We notice that these issues both relate to participation or ongoing participation of patients who do not have a treatment decision maker. The first scenario is where the participant remains unable to consent after the first intervention and no treatment decision maker can be found, and where the trial protocol envisages that the patient's participation will be discontinued even though the absence of a decision maker is not specified as an inclusion criterion, and or the stated reason for this is the complexity of paperwork to be undertaken. The second scenario is where the research protocol does not specify that this class of participants is going to be excluded, but then it is discovered that this is in fact what is happening in an ad hoc fashion as the trial progresses. These approaches, I think, have the unintended but undesirable result of narrowing the class of participants in clinical research on grounds such as administrative inconvenience, which is also objectionable. Put simply, many people in the community are non-English speakers, do not have the education or knowledge to have executed advanced directives or appointed medical treatment decision makers, and some do not have the benefit of relatives or partners. They should not be excluded from clinical trials because investigators consider it is too onerous to draw up a certificate and send a copy to the Public Advocate's Office as required by Sections 80 and 81 of the Act. The Public Advocate's Office has provided a checklist of how to comply with the provisions of the Act, and pro forma documentation can be prepared, signed and kept on file as part of ordinary trial documentation. I've spoken to the relevant people at the Public Advocate's Office and been informed that they've only received 17 certificates on file to date. So given the number of clinical trial projects underway at any one time, there may be systematic exclusion of this class of participant happening without justification, and that is a cause for concern, particularly if the reason is clinician disinclination or sloth or just the additional burden of the paperwork. There are very, compelling reasons given in the literature about generalisability of data to support the widest possible class of participants in clinical trial research, and so I would encourage investigators to take that into account. So the last thing I wanted to raise was probably this issue just in very broad terms of placebos. No, before I do that, so I've dealt with that. So I really wanted to encourage investigators to take into account that we do have a very enabling environment in Victoria for the conduct of research. You probably all know that in the UK, for example, in spite of great number of studies which showed that it would be a good idea if they did enable emergency research, they don't have it because they won't get around or can't get around the requirement for informed consent, and so they just don't have it at all. So we are in the very fortunate position of having an Act which enables some of that research to occur, and we should make full use of that, keeping in mind the principles set out in the National Statement and the Ethics Committee approval system. So we should be using the Act to its full capacity. Finally, I just wanted to address the issue of placebo, and I know that that's going to be dealt with later and probably be the subject of discussion. And again, as part of an ethics committee, we consider, having regard to the national statement and to relevant Victorian law, research projects one at a time. And the role of placebos in medical research generally, of course, is well established. The Declaration of Helsinki, which is an international guidance document which may be a convenient starting point for consideration of the issue, permits placebo-controlled trials in medical research generally, and revision 7 of the document in 2013 included a placebo paragraph permitting placebo clinical trials in cases in which no standard treatment exists, or where there is, provided there is a compelling scientific rationale and sound methodological reasons. In addition, the paragraph also permitted any intervention less effective than the best proven one is a justifiable alternative to the best proven treatment. This is subject to the requirement that the patient is never subjected to an additional risk of serious or irreversible harm if standard treatment is withheld. Of course, the declaration does not define serious harm and compelling methodological reasons, and nor does it set out what the optimal means are of avoiding the abuse of an option to use placebo controls. However, various national bodies and academics, in particular the ethicist Julian Savulescu, have produced guidelines which may be of assistance. So, given the emerging evidence that there is a treatment effect that is a benefit to participants from simply being enrolled in a trial and participating in it, regardless of whether they're in a placebo arm or not, it may well be that some of the controversy around the use of placebo will fall away over time. But in any event, as I understand the literature, the objections are not around the use of placebo per se in a clinical trial, but the use of a placebo alone. There is, I think, there can be no objection to a placebo arm where the trial design provides for both arms receiving standard therapy and then randomisation to placebo or study drug on top of this, and we routinely approve such trials. But in relation to emergency medical research, we have the guidance provided in Section 53 of the Act, along with the Declaration of Helsinki, the National Statement, and the other national guidelines which might be relevant and useful to our deliberations. Again, there may be no obstacle to the inclusion of a placebo arm in addition to standard therapy, as the provision of standard therapy would address all of the considerations set out in Section 53 of the Act. And the issue which may arise concerns timing, such as where randomisation to an additional investigational drug or placebo on top of standard care occurs at a different time or before standard care and at a different location to where standard care is given. I think that may be the example that's given is the ambulance stroke trials. However, it appears likely that for ethical reasons, ethics committees and even perhaps the purveyors of national guidelines, wherever they are, will not approve trials involving emergency randomisation to placebo alone as the alternative to the study drug or the intervention, where or because no informed consent can be obtained, but also due to the pressure of time. But now, in the context of this Act, the difficulties that we might have in fulfilling the considerations set out in Section 53 of the Act. So I don't have any comments on how we will address those. I do think, however, that the piece of legislation is a piece of legislation which has to be construed against the background of the whole scheme that we are looking at, which is the national statement, which is all of the literature that exists about clinical trials, the efficacy of them, the rationale for them, and we have to take those matters into account. My final point is how we educate ourselves about the relevant ethical issues in multi-centre emergency and ICU clinical trials. Clearly, one issue arises where there are multi-centre proposed trials in Victoria, which will be seeking the approval of more than one HREC. It would be desirable for all of the HRECs involved to obtain similar levels of information, education and specialist input as to the ethical considerations involved and to the extent to which the proposals adequately address those considerations. So I do think it would be useful to have a process that would, in the context of these applications, require the investigators to demonstrate familiarity with the literature concerning the ethical issues that arise in such trials, particularly if they're proposing a placebo-only arm to the trial. They're going to have to do a lot of hard work to persuade anybody to approve it, but really the challenge is there, and it may well be, again, that those concerns may be overtaken by further developments in clinical trials research. But for the moment, I think that we should get them to demonstrate that they're familiar with the literature, they've taken seriously the concerns that are raised in it, and they've demonstrated an adequate response to the concerns raised in it. But where appropriate also to invite an ethicist or a person who's expert in addressing those particular issues to speak to the committees, either separately or together. And finally, to reach consensus, if possible, about the matters upon which HRECs will need to be satisfied before approving such projects. Because ultimately, all of us on the committees are just people who may have opinions, but evidence is everything, and obviously the best evidence is not lots of opinions, but the best evidence is people who've listened carefully to the research that's been done by others on these things, informed themselves, and then made a reasoned decision or determination in the light of that best evidence. So our best evidence is what the investigators tell us, what the experts will tell us, and then we have to keep in mind that we're not experts, but we are trying to do the best we can to navigate a complex landscape. But we should do so trying to enable the progress of randomisation as opposed to the continuation of random medicine. So, thank you.
I'll just see if anyone has a
sure.
question. Does anyone, thank you, Judge Davis. Does anyone have a question for Judge Davis? We can take a couple of questions. Yes? Who does? Professor McCarthy. Thank you.
I just wonder if you could comment on the current construct of the law, which says we can do emergency research if we believe it is life-saving. And of course, most of the time we're doing research because we have no idea whether it's life-saving or not. But the premise that we operate on is, if it is going to work, it has to be given quickly. Therefore, I will say that it's an emergency and it is life-saving. And do you think that the current legislation environment is inadequate for the purposes of emergency research?
I think you're never going to get comfort. I mean, the last round of the Guardianship Act that I had to operate under, it was produced as a cabinet compromise without consultation to the medical research community. This bit also seems to have suffered the same fate. Don't know how it got there. Hope other people do know how it got there. Wish it wasn't there in that language. It doesn't seem to have any qualifications. But yet it's something which has to be construed not by itself, but in the context of the entire Act and what the Act's designed to achieve, and then also construed in the light of the governance provisions, the ethics committee role, the national statement role. So I think there's a lot of work to be done. To be frank, I think there is a way, and I'm sure Julian Savleska could tell me exactly what that way is. I think there is a way of addressing it. I'm not quite sure, and I haven't yet obviously spent enough time ploughing through. There is just so much stuff that lies behind it. And on the one hand, I think once you decide that if it's about randomising on top of standard care, I don't think there's an issue, because the person is getting standard care, and if soon will be overtaken because there'll be a demonstrable beneficial effect just of enrolling the person in the trial, so we can put that aside. The question is, if you're just going to randomise them to that placebo by itself and nobody's giving consent, is that going to be something that's sought to be done? I don't know how much it will be sought to be done, but if what you're saying is people are sort of doing it randomly ad hoc, well, that's sort of not science. It may be random medicine, but it's probably not research. And then the question is, if you really want to do it properly, you go and talk to your expert and find out how it's done. But I think there is a way, but I'm not quite sure how that is, how it is. Right.
Thank you very much. It's a fantastic presentation, and I really appreciate your summary of the different provisions of the Act to allow enrolment of patients into clinical trials. I'd just like to seek your thoughts on a not uncommon scenario where a patient is enrolled and randomised in a clinical trial under Section 53 emergency provisions. And as you've already alluded to, the situation is full of drama and often grief, and then the patient then eventually succumbs to their injuries or illness. Mm-hmm. In that time, it's been possible to identify a medical treatment decision maker, but it's not been appropriate to approach them to get further consent. Mm-hmm. Is there any consideration by the Ethics Committee, or even anything in the Act that allows the investigators to continue to use that patient's data?
Well, I just don't think there really should be an objection to using that data. After all, they were enrolled. If they didn't have the benefit of any relatives, the idea that you wouldn't enrol them, again, just excludes one whole class of participants from your clinical trials. My view is, once they were enrolled, after all, you're not subjecting them to further procedures. It's the administrative follow-up that follows and is integral to the process by which you enrolled them in the first place. And since the project has been approved and the intervention's taken place, in my view, if the patient dies, I don't think there's the privacy concerns and all the concerns. There is no substitute decision maker who can retrospectively consent anyway. The person's dead, they haven't recovered their capacity. That's really the end of it. You enrolled them in the trial, and I think everything that flows from it, including the data, is fair game. Otherwise, again, you're excluding them, and then your data becomes skewed. And also, that's not anticipated, so it's not in the protocol, and that's the problem. It's a random happening along the way, which isn't monitored, isn't documented. And that's, I think, probably not a good idea for all sorts of reasons, but partly because it might lead to people being progressively excluded for all sorts of non-eligibility criteria reasons, which would be unfortunate. Yeah. Yeah, well, lawyers say the same, that's right.
We can probably take one more question.
Yeah.
Under Section 80, I think it was, you can enrol somebody if you think that they would be in favour of being enrolled. I'm not quite sure how you would get that information if you didn't have one of the medical treatment decision maker.
You might have somebody who doesn't qualify in that strict hierarchy, but who can say as a good friend, I've been their friend, I've been a friend of theirs their whole lives, and I can say that they wouldn't have wanted to linger in this state, or etc. And sometimes you'll take that into account, because there are lots of people in the community who are supported by people other than their relatives, but who don't have authority effectively to make decisions for them. Yeah.
And what about when they regain capacity? If they say, "Oh no, I wouldn't want to be enrolled," does that have any legal redress?
I wouldn't have thought so. Not if the system's working as it should. There are provisions in the Act that cover researchers for doing things bona fide in the belief that their project has ethics committee approval, etc. I mean, being litigation conscious as an independent physician is one thing. Being worried inside a trial day by day when you're making decisions is probably just likely to confuse you and lead you to make errors, because at the end of the day you should have the confidence in the fact that you've got the approval, that you know what you're doing, and that if you can't get consent for follow-up because there are no relevant people, well then you can do X, or you can keep looking, which I think is a requirement under some provisions, but you wouldn't have to keep looking beyond the life of the trial, and you certainly don't have to keep looking beyond the death of the patient. So there's sort of assumptions built in about the reasonableness of your efforts, that's all, whatever's reasonable. Thank you.
There are a series of basic rules when you appear as a general counsel, and I'm about to break most of them. The first rule is when you're giving advice on a particular provision, don't make any extra statements or they'll ask you to present on them in a symposium. The second rule is if you are going to another hospital, don't assume that everybody at the hospital knows where building B is. Don't assume that it's going to take you less than an hour to get there. And one of the last ones is if you're going to appear after a judge, don't explicitly disagree with her, which I'm about to do. I am presenting essentially a very legalistic analysis of Section 53 of the Medical Treatment Planning and Decisions Act. I don't apologise for it being legalistic, but I acknowledge that it is legalistic, and I'll try to make it as clear as I possibly can. The positions that I want to take is that the legislation imposes 5 requirements in relation to medical research procedures in an emergency where you do not have consent or you are not proposing to use the procedural consent provisions in Section 80 and 81. Placebos fail at least one of those requirements, and arguably they fail two. Certainly in specific circumstances. And then my final point, the so what about all of this, is practitioners who want to utilise placebos should be using the procedural consent processes or obtaining consent from a medical treatment decision maker. The specificity requirement. A procedure is not a protocol. The definition of medical research procedure looks at specific interventions. And if we go back to the wording of Section 53, you are required to look at each of those interventions of themselves. You are not allowed to talk about a whole protocol. You therefore have to consider the intervention that the protocol requires each of them individually. And each intervention must satisfy all of those other 4 requirements that I've just gone through. The next point is that the intervention, and each intervention must be necessary to save the patient's life. It must be, or to prevent serious damage to the patient's health, or to prevent the patient from suffering or continuing to suffer significant pain or distress. There has to be that link to the person you are administering the procedure to. You cannot be doing this for the greater good. You cannot be doing this to boost medical knowledge. Although those are laudable aims, they are not justified under the legislation. Finally, there needs to be a reasonable basis. It doesn't have to be the totality of the evidence. You just need to have good reasons based upon the current state of medical knowledge to believe that this is going to work. So if we were suggesting that we're going to use acupuncture to cure chronic COPD, then you'd have a problem. On the other hand, if you think that there is certain medication, based upon what we know about analogues of that medication, then you probably have enough. Are there any questions in relation to those requirements? Because I'm about to talk about placebos and I don't want to get lost in the discussion about placebos before I move on to, about the discussion about the requirements before I move on to placebos. Great.
Just comment.
Yep.
If I understand you correctly, and I agree with you,
Yep.
the current legislation in Victoria means you cannot enrol patients in emergency research because there's always equipoise when you do a trial. You don't know whether it works or it doesn't work. So you can't fulfil those criteria of saying that it is life-saving or is going to prevent harm to a patient. Your hypothesis is that it might, but you don't know.
You are not required to know. You are required to believe on a reasonable basis. I think there's a difference between those words. Okay, so what are we talking about in placebo? By definition, if we're using them according to what we believe is the case, placebos, as distinct from being enrolled in a clinical trial, provide no benefit to the patient. And there is evidence to suggest that this is the case. This is the last thing that General Counsel shouldn't do. They shouldn't cite Cochrane reviews to a bunch of medical practitioners. There is a Cochrane review from 2010 which involves the quite remarkable access of people who have compared placebos to no treatment at all and have indicated that there is no difference between no treatment at all and the placebo except in relation to pain and nausea. And in circumstances where a person lacks capacity to consent, in many of those cases, you're not dealing with a placebo in relation to pain or nausea. So there is an evidentiary question about whether or not the placebo is going to achieve anything at all in comparison to no treatment at all. Now the question is this what Parliament intended? And when I've been asked that question, my answer is that that is irrelevant because the wording of Section 53 is quite clear. It says there are specific circumstances in which it is acceptable to proceed without consent, and placebos simply don't meet these circumstances. And if you want to put it another way, there is nothing to suggest from Parliament or anything in the Act that it's okay to experiment on people without their consent. The Helsinki Declaration assumes that there is a degree of autonomy associated with the participant when they choose to enrol. And that's what allows you to engage in processes that don't have the level of certainty that you might otherwise have. The other thing that I'd say about this, and Her Honour was absolutely right when she noted this, is that procedural consent, despite being administratively burdensome, or at least administratively more burdensome, is a clear process that provides this type of consent. And it can be utilised for emergency procedures. It's just a bit of a pain. Now, the difference is it's a pain that can be discharged before the event. There are protocols that can be put in place and your general counsels can assist you with them in order to ensure that you have a decision process, a checklist in place that will allow you to utilise procedural consent processes in an emergency situation in the heat of the moment. So what now? The first thing to do is to consider whether you need to use a placebo at all. As I've pointed out, it's not necessary in many cases, and it may be possible to compare your intervention with no treatment or with the standard of care. The second thing you could think about doing is consider placing this particular group of patients into a separate group that supplements analysis of the traditional case. So you don't randomise to a placebo, you shuttle all these patients into a specific group that receive the treatment. And then you add them to any analysis that you do later on. And the last thing to do is to utilise the procedural consent processes and acknowledge that this is a more involved process and write your MP if you have a problem with it. So That's it. That's a relatively straightforward process. Does anybody have any questions?
How would you implement procedural consent in a cardiac arrest?
I'd have done it beforehand. So in circumstances where a cardiac arrest is possible, I would have engaged in a protocol. I'd have a checklist in place to say, do we have a medical treatment decision maker available? No, yes. Have we had a very specific question that we can ask? No, yes. All right, then we're okay. Have we got the ethics committee approval in relation to these circumstances? No, yes. Okay, we're fine.
For every patient in the trial at home while you're doing CPR, is that right?
It can be 3 questions. The legislation requires that you undertake a search for the medical treatment decision maker or inquiries in relation to what the patient would have want. That is reasonable in all the circumstances. It is reasonable in all the circumstances to ask one question. And if nobody knows the answer, then you've done what is required under the legislation. That's always a bad sign when nobody has any questions.
Just go through that one more time for me. So say there's like a trauma or a cardiac arrest. What are the 3 questions, or what are the sort of 3 processes you recommend doing in a time-pressured way? Just explain.
So you are required to ascertain whether or not there is an instructional directive. Is there an instructional directive? I don't know. All right, no. You can include a default process where nobody knows the answer. You're required to find out whether or not the person is there is a medical treatment decision maker present. Who are you? If no one's present, that's your default, no one's around. In circumstances where there's absolute urgency, the legislation is flexible and allows a very, very quick process that's reasonable in the circumstances, including from the paramedics. Before the person comes into the hospital, it is absolutely reasonable to rely on what the paramedics tell you in an emergency situation.
So David, if we say that, for example, the scenario that Rinaldo has presented, a patient arrives to the emergency department who's in cardiac arrest,
Yep.
and they happen to be followed in a chase car by that person's medical treatment decision maker.
Yep.
The suggestion there is that we would then have a consent conversation while CPR is ongoing because of legislation.
So the question, is CPR part of the clinical trial protocol? Would be the question that I'm asking to start off, to contextualise it. If you're doing some kind of new and evolved CPR, then probably not. No, if you have reasonable belief that it's going to save the patient's life, then you think you're okay. In circumstances where the clinical trial protocol relates to something else later on, then you need to work out how much time you have.
Yeah, I'm struggling a little bit because the clinical scenario whereby someone is gravely unwell, acutely unwell, and a family member is acutely distressed to consider even a short conversation about informed consent for a clinical trial in that context.
But there are a number of circumstances in which a patient becomes extremely unwell. A patient might be extremely unwell in a way that you could understand as an intensivist. You say, this patient is deteriorating and at some stage they're likely to go into cardiac arrest. All right, we've got a medical research procedure. We want to enrol the patient. Let's have a chat to the family member now because we can see which way it's going and we can do it conditionally. I think that this patient, I think that your father, I think that your son might be having these issues. It's likely to involve a cardiac arrest. Let's sort that out. Have that conversation. Another circumstance is when the patient could be in another procedure and one of the likely outcomes is a cardiac arrest. The last circumstance is the one that you're talking about where somebody's on the golf course and drops down.
Well, yeah, the vast majority of the patients that scraped off the road.
Or scraped off the road. Yeah, absolutely. There are going to be unforeseen emergencies. I completely agree. But there are, and what you need to do is to work out whether the clinical trial can be modified or the protocol can be modified in such a way as to ensure that in those circumstances you can do what the Section 79 and Section 80 require. And if that...
Someone gets scraped off the road, is brought into the emergency department and followed by the medical treatment decision maker. The act says we've got to find somebody, and with someone standing in front of me, while they're having an emergency procedure. I cannot see a scenario where I can have an informed consent conversation. I can't.
But then they may not be willing. Isn't that part of the wording? That they have to be willing and available? They might be available, but they may not be willing.
So let's assume the conversation that you want to have. So what we actually end up with is a situation where you're saying, what do I need to do in order to obtain informed consent? How much information is necessary for me to communicate to the medical treatment decision maker or to the patient in order to ensure that they have informed consent? Is that really what this boils down to?
Well, I don't actually believe informed consent is possible in that scenario. It's my personal view, and I don't think it's actually remotely fair on a family member, although I appreciate you have presented the Act from a legalistic sense, to remotely expect that they were taking information to make an informed consent decision in that scenario. And I think that the way the Act is written means that we have to, you've suggested that it has to be done before we can then move to procedural authorisation.
Yes. So there are a couple of things. Let's be clear. One, you're not required to obtain informed consent. If you want to enrol them in the medical research procedure, you're required to undertake a series of processes. The second thing is, as a general rule, and Nick might back me up on this, I think doctors have a much higher understanding of what is required for informed consent than lawyers who are paying attention to the law. There is legislation, and the Medical Treatment Planning and Decision Act is the start of that legislation, that says a patient is presumed to have competence unless there's clear evidence to the contrary, that patients can be given more assistance where necessary. And I think that there's a general view that you really need to acknowledge that the floor's lower rather than higher in relation to consent and the capacity to consent. So I'm not going to speculate on specific cases, but if it were a situation where you were able to reduce the suggestions to 3 or 4 sentences that don't necessarily involve an explanation of the hypothesized physiological changes or differences, that simply say, this is something that we would like to do, we've got good reasons for doing it, here's some information we'd like to do it, then you are in a position where you can provide the information that's necessary in a short period of time.
Does it come down to that phrase, what is reasonable under the circumstances? Like the use of the word, what is reasonable?
So that depends on what you're talking about. If you're talking about reasonable inquiries, yeah, absolutely. It's very, very quick. In terms of informed consent, then you're in another area.
Good afternoon, ladies and gentlemen, and thanks very much for the invitation to be here. And I'm pleased to follow David's presentation and to hear how the application of the law can sometimes be different to perhaps what's intended, or the circumstances of how it's applied are much more complex than what's sometimes contemplated by Parliament. I propose to do a higher level look, and thanks Adam for the invitation to speak today. And as Yasmin said, the presentation is about an insider's look at how the law is made. Some of it may please you, some of it may, I think, surprise you. I'll leave that to your judgment over the next 15 minutes. Much of what happens in society is not regulated, and the Parliament needs to make a conscious decision about what should be regulated and what should be left for civil society to determine in and of itself. And sometimes that regulation is best done by legislation, sometimes it's best done within a health group, like you've just been discussing. Sometimes it's best done through actual legislation. The way law is made depends on the law. The Victorian Parliament passes legislation every week with cross-party support that is uncontroversial, that may be as simple as updating acts so that the references are the same, the language is contemporary, and a change of practice has been reflected in the way the legislation is termed. In that sort of context, very few people will actually look at the law in any depth because we understand the purpose is fundamentally administrative. Sometimes laws come through generated from the bureaucracy, put out for exposure drafts, community input, and that will shape the way the law or the legislation looks. The final approach, which I'll talk in with a bit more detail is the parliamentary committees. Parliamentary committees is really the way that legislation is, the genesis of the legislation or the policy, and right through to the completion of the passage of the legislation has real detail and real input and oversight from the Parliament. The great thing about parliamentary committees, of course, is that they're generally cross-party, bipartisan sort of approach, and public policy outcomes are the driving, really the overriding driving factors in the development of the legislation. A couple of key points about what legislation should cover. I know many people think the state should be done away with, and that's an argument which, on one level has merit. But one of the great things about our federal system that we have is it drives competition and innovation. When we're looking at legislative change or a way to improve things, the first reference point is, well, what happens in New South Wales? What happens in Queensland? Who's doing what, and what can we improve that they're doing, or what are we doing better that perhaps gives a signal that we're doing things reasonably well. As I say, community consultation and input is often always critical as well for good outcomes. That's taken from the parliamentary website, so the process can be exhaustive and can take quite a significant period of time, depending on the Act, for it to go from originating, being drafted, through the lower house, through the Legislative Council where I'm a member, and then for royal assent. The issue of royal assent is something which doesn't really get examined much, but just as a little aside, the Parliament passed in a day legislation yesterday to sack the City of Casey Council, following the Independent Monitor's report and some of the allegations that have been aired. The council met last night because the governor was unable to give royal assent before the council meeting commenced last night. So royal assent is obviously, laws aren't valid until they receive royal assent. As I said earlier, the amount of scrutiny that a piece of legislation or analysis can depend on the makeup of the Parliament. It can depend on the amount of interest from members. The process can be less robust perhaps than what the community may expect. The Legislative Assembly, and I'm not saying this in any partisan way, I'm just saying this is the way the Parliament operates, and that can be generally consistent, so make that point. The Legislative Assembly has what's called a government business program. Bills that are listed on that government business program, when the guillotine comes on Thursday evenings at the end of the sitting week, those bills are deemed to have passed. So debate may have only been halfway through, maybe a range of questions that exist around the topics that you were just discussing when I came into the room, and debate will stop and the legislation passes and it goes through the upper house of Legislative Council. The Legislative Council has, as of right, capacity for members to ask the responsible minister questions about the bill for as long as they wish. Now, in discussing tonight with Adam, we were talking about the composition of the Parliament, and Adam was asking me about how many medical practitioners or how many people with medical knowledge sit in the Parliament. And I didn't have a precise answer, so I went and just had a look, checked out the 128 members. There's one doctor, 2 or 3 nurses, a former CEO of a rural health service, some allied health professionals, and that's it. So when you're asking questions about a situation, a live situation in an ICU, the honest answer is we don't have the answers to those specific questions, and really, nor should we. Because if you're too prescriptive in legislation and situations change, the legislation is either wrong or redundant, which can create more challenges and problems than you're trying to solve with passing the legislation in the first place, and hence the use of the term reasonable in so many situations, and in particularly situations where things change. And a few examples here of where legislation can often become out of date quickly because of technology or changed community expectations or changed community attitudes. And the medicine obviously is, you know this better than I do, medicine is a situation where that perhaps is one of the best examples. Just today the government's announced they're going to change the IVF legislation so that applicants no longer are required to undergo police checks. So, you know, an example perhaps where the law will catch up with community expectations. At the bottom here, Victoria, I think, prides itself on being a driver of good policy and legislative reform when it comes to road safety. The Parliamentary Road Safety Committee back in the late 1970s was the first jurisdiction to recommend compulsory seatbelts, and it's gone on from there to random alcohol and drug driver testing and other policy changes. I mentioned before the benefits of parliamentary committees. Parliamentary committees give MPs the time to go and properly examine an issue in depth. As I say, often the politics is removed. You're working together as a group of usually 7 members, 2 from Liberal, 2 from Labor, maybe a National, a Green, and 1 or 2 others, and you end up working collectively together. The committees have all the benefits of the Parliament, so parliamentary privilege applies, and the ability to call for production of documents and witnesses with subpoena if necessary. So you have the ability, you have real power to get to the bottom of issues if that is necessary. As I say, there's different types of committees: joint committees, standing committees, domestic committees. Committees can come from the Parliament itself, from the government, or committees can actually self-reference. I'm a member of the Legal and Social Issues Committee, which has oversight from a departmental basis of the Department of Health and Human Services, in addition to Premier and Cabinet and Justice and Regulation. One committee, and that's the list of some of the committees' reports that that committee has undertaken. I don't have a medical background. I'm a lawyer by training, and I sat on the organ donation inquiry, which I found to be absolutely fascinating, and to be able to hear. I still remember Andrew Way from the Alfred giving us evidence, just the absolute experts giving their perspective on what we should do as parliamentarians. Is actually such a privilege to be able to hear that have that direct communication with leaders in their fields about issues of public importance. I was the chair of the Legal and Social Issues Committee when we received the End of Life Choices inquiry. Not something that I had thought would come our way, or something that I particularly wanted, given it's very contentious. But that was a fascinating process, and an example where the Parliament did a deep dive into the issues, a deep dive into community sentiment, and heard from the experts and heard from all ranges of public opinion. And there's a summary of what some of the things we did: 17 days of hearings, 154 witnesses, over 1,000 submissions, public hearings right around Victoria. We went and visited jurisdictions which have legalised assisted dying. We went and had public hearings at Bowen Health, Honourable, and at the Austin, which was fantastic. And that committee report made recommendations that led to the legislation that you're considering tonight. And I was rereading the debates during the debate on the Medical Treatment Planning and Decisions Bill. And Jenny Makakos is a Labor minister. She wasn't the health minister at the time, but she is now. And because the health minister doesn't sit in the upper house in the last parliament, Jenny had carriage of the legislation for the government. And I thought her summary there was a good catch-all of what the Parliament was intending to do. And to the question of what is the Parliament's intention, the Parliament's intention is generally pretty high level. Sometimes it gets into the nitty-gritty and the weeds. But as I've said before, I don't have the experience to understand what you should do in an ICU when this happens and that happens, or with a paramedic, or if they're not in the ICU, etc., etc. And I mean, so that's, I think, is the intention of the Parliament. I think to summarise the intention of the Parliament particularly with medical practitioners, and there's such a high degree of respect for the work that medical professionals do in the community and in your workplaces. I think the overall intention is to create a framework that works for you whilst limiting risk of misuse of those powers that the Parliament is conferring. And that's a very general sort of statement, but I think that's probably summarises the attitude of the MPs and, to a certain degree, the depth of knowledge. There's a high degree of deference, I think, to the decisions that medical practitioners make in their judgment at a particular time. And again, the term reasonable, helps to be a bit of a catch-all that in the circumstances at a particular point of time, a particular snapshot, that decisions are made in that context. Adam asked me a couple of questions. Adam asked me to address, in addition to the background of MPs, when drafting legislation, how much weight is given to how an act can be misinterpreted or abused in the future. I think the Assisted Dying Act is a piece of legislation that's had more scrutiny than any other in my 13 and a half years in the Parliament. And one of the key focuses of the inquiry report that I chaired was the safeguards aspect, and the government, after the review by their expert panel, were very keen to focus on the 68 different safeguards. Now, I appreciate there's a range of views about this actual issue, but in contentious legislation, the focus on protecting from abuse in the future is a strong focus, and again, getting that balance between making the law work and accessible without it making it too burdensome is always a difficult balance to find. Adam's asked some more specific questions. How would I interpret Section 53 and Section 75? And I suppose I make the general point. In the start of my talk, I said many areas of public policy actually don't need to be regulated. They don't need legislation. So when the Parliament takes a proactive step of saying we need to legislate this, and here are the steps by which we consider this power should be exercised, that to me is a very strong statement from the Parliament that the legislation that we are authorising or giving the Parliament's consent to this activity under these circumstances. And in my humble opinion, as one of the legislators, that would be the starting approach to the analysis and answer to any complex question that you may have about a particular circumstance. The Parliament has consciously contemplated this situation and said, in these circumstances, we believe this should be allowed. Noting then that legislation is generally high level, and then it is operationalised, for want of a better term, either by regulation, by departmentally drafted regulation, or through your ethics committees or other processes that health groups have to make legislation work and to operate effectively. So, as I say, that's a higher level look at the way these complex questions you have come to perhaps be asked and how the legislation may be drafted. I hope that's been of some use, and thank you very much for everything you all do in the community to deliver what we have is one of the best health services in Australia and in the world, and we're very, very lucky. And to all of you that make that happen, as a humble non-medical person, thank you very much.
After listening to Rinaldo's talk, I thought I really should do a Nancy Pelosi and rip up my own speech because he gave me so much to think about that I have not addressed. But the question I was asked to address is, if I was unconscious, would I be happy for my doctors to do research without consent? If I were unconscious, I would hope that my doctors would do all they could to find out what was wrong with me and treat it. That's the bottom line. It's not about research. Find out what's wrong with me and do something, fix me up. I wouldn't consider this to be research, but I would consider it legitimate investigation. I think of research as a more abstract thing, a more general, less immediate inquiry, something set up with specific parameters to look at particular issues. So, when I had hyperbaric treatment, I signed up, did a research questionnaire before and a research questionnaire afterwards. But that's not so much what happens in the ICU. When I was a patient here, and Jeff Presnell said, "Valerie, you keep throwing curved balls at us." Oddly, I found this very comforting. I thought it takes a big man to say we don't know what's going on, but we're going to try and find out. I was very glad then that he and his team got on with doing all they could to find out what was wrong. I didn't think of this as abstract research. It was something much more immediate. I would hate to think that my doctors felt constrained by legislation so they couldn't get on with the job of finding out what was wrong with me and treating me. In a legal context, perhaps we have to think more about definitions. For me, I reflected, what's the difference between research, and now I've got a new word, trialist, I didn't know that one before, investigation and treatment, even experimental treatment. Is that a little bit of research? Maybe we'll just try this, tweak the treatment a little bit, maybe it might work. I want to stress that I'm very supportive of research. I agree with the judge who said patients do better in an institution where there is a high value on research. I've been a year in there in the intensive care and I've done fine. I have a hard-to-treat neurological condition. For 15 years, I have had recurrent episodes of it, and each time I was hospitalised, I was treated with a drug that had very unpleasant side effects. We always asked whether there was some way to prevent the neuropathy attacking me again, and the answer was, for 15 years, was no, there's not. If there was anything we could do, we'd be doing it. But then suddenly there was something that could be done. A drug could be used to suppress the neuropathy. I started treatment with that drug and I've been free of the neuropathy ever since. Presumably, it was research that came up with this new treatment. Someone must have said, let's see if rituximab works with CIDP. Turns out it does. Hallelujah. Thank you, inspired researcher. I've been a patient representative on the quality committee of the ICU for about 10 years, and I have been tremendously impressed by the amount and quality of the research carried out over that time. sometimes there's things I can understand, like how do you keep patients pooing when they're in the ICU? Or something like, is it better to use a drug after surgery to suppress nausea or just chew chewing gum? And then there's much bigger things that I don't understand. But unlike the Conservative politician on Q&A, who proudly claimed that no evidence shaped his opinions, here evidence reigns supreme. It clearly informs the practice in the unit, and this is one of the reasons why I just love being involved with the team in our ICU and why I think it's such a splendid place. Thank you.
All right, so I'm going to outline a case and then we'll cut to a few of our speakers for their input on what their opinion is. We won't be able to discuss this for hours, but I'm sure that we could. So the case is, there's a young woman. She's brought in with low blood pressure to the ICU with presumed infection, which we term septic shock. She's receiving an intravenous medication that increases the blood pressure, which is called noradrenaline, at 15 mics a minute, which is a moderately high dose. Noradrenaline is usually administered via a drip into one of the main central veins of the body via central venous catheter, but this patient's receiving the vasopressor drug via a smaller venous catheter in a peripheral vein. This is sometimes done in an emergency so that we can start noradrenaline quickly prior to obtaining central venous access in the ICU. Professor Bellomo, how urgent is placement of a central venous catheter, and do you obtain consent for this procedure?
This is not a research undertaking. This is a clinical care decision, and of course the urgency of it is significant but not overwhelming or immediate. Now, to go and get consent for this kind of intervention would be overly burdensome. It's part of the standard care delivered in ICU. The patient is admitted to ICU, and that implies that all of the care that is part of ICU management should be delivered. And I think trying to get consent for every step of the way, intubation, central line, arterial line insertion, and the implications that that would have for everything that we do, because then you have to say, well, if a surgeon could stop the operation for 10 minutes and ask the family whether they should use this particular screw, this particular nail for the broken femur, becomes insane. And so personally, I think that's part of ICU care and it should be delivered according to medical judgment.
So, thank you. So this woman is receiving usual care, including antibiotics and fluids, but her condition worsens with increasing doses of noradrenaline. The treating team are worried that she may die. The treating intensivist, say it's me, I've read an article about vitamin C and I think it might be useful, but it needs to be given urgently if it is of benefit. Vitamin C is approved for use by the TGA, but is not accepted as usual care. Should I obtain consent prior to administering vitamin C if I think it might be of benefit? Mr. Ruschena.
The advice that I give is if you can obtain consent, you should obtain consent. It's pretty much that simple. There might be other ways around it, but I'm not sure that there's a really good reason to not to obtain consent when you can obtain consent. I just want to point out one or two comments in relation to Professor Bellomo's previous statements. There is nothing wrong with obtaining generalised consent, and I understand that that's what many intensive care units and intensivists do, which is to say to the patient or to the medical treatment decision maker, there's going to be a lot of things that we're going to do. A lot of them are going to happen every day, every shift. You're going to have nurses coming in, you're going to have doctors coming in. Let's talk you through some of those things so that you have a general understanding of what we'll be doing and why we'll be doing them. It's not necessary to obtain consent to the same procedure again and again and again and again. And if you produce it, if you do it in the right way, there is no requirement to obtain consent to the specific screw. You can say, we'll be using the screw, there will be screws used, we'll work out which one is appropriate in the circumstances, assuming that there's a choice. It's perfectly reasonable to have a general conversation in advance where possible.
So just carrying on from that, if the vitamin C actually was going to be administered as part of a trial and the patient was going to be randomised to receive vitamin C or not, should the woman receive the vitamin C without informed consent? You've touched on this a little bit.
Assuming that she's conscious and competent, I think that it would be wrong. I say that. It would be legally risky, especially in today's environment, to administer medication to a competent and conscious patient regardless of whether or not you have legislative authorisation to do so.
All right, so Judge Davis, if the trial includes placebo, what is your view on whether the woman can legally receive placebo without informed consent?
Don't know if I want to answer to enter the lion's den. I suppose it really depends, doesn't it? At the end of the day, is she getting? I disagree with the previous speaker, and we probably will continue to disagree. But my view is that probably in the context, emergency provision of placebo alone without being on top of standard treatment, I have my reservations. I think not. If it was a carefully executed trial in urgent situations, I doubt it. I actually doubt it. I just think for the moment I doubt it, but it may well be that we get overtaken by research.
The situations that we find ourselves in is, to return to some of the discussions around placebo, is this. We are administering a medical procedure or a medical intervention that we believe is in the patient's best interest. We just don't know if the patient will get that intervention which is given to 50% of the patients or not. So in order for us to deliver, imagine for a moment you got somebody is at home. Imagine a friend from the Alfred just dropped dead with a cardiac arrest. And he's just lying on the floor, and we got this new medication. we got this medication that has been made available to us as part of a trial, which is a randomized double-blind placebo-controlled trial, that has been shown in animals to increase the likelihood of successful resuscitation. Okay, and it needs to be given immediately, right? So we are in a situation where the only way we can make that available to him is as part of the trial treatment. Otherwise, we would never be able to make that available to him because the protocol for this drug, provided by the United States manufacturers and approved by the Ethics Committee, demands that it be a randomized double-blind placebo-controlled trial. So when I'm giving him the medical intervention, my intention is to give him a treatment that will save his life, which I can only make available to him with the understanding that he's got a 50% chance of getting it through this trial. So my intention and the treatment and what I'm trying to give to him is a life-saving treatment. Now, he might get placebo, but I am administering a treatment with the reasonable intention of saving his life, which I would not be able to do in the absence of that trial in a randomized double-blind placebo-controlled setting. I clearly can't get consent because after all the discussion, most of the people in the audience would not want me to treat him. But also, I'm joking, but also because there is no medical decision maker available and I have to make that decision in the next minute or two. And there is no way that I can communicate and obtain any information. And so what worries me is the conceptual framework that the intervention, the medical procedure that I'm giving can only be the trial drug, when in fact the intervention I administer with the intention to save his life is the intervention provided through the trial, which otherwise would not be available.
So there are a couple of implications. The first thing to note is that the statement that we are acting with the best interests of the patient does not reflect the law in Australia, in Victoria anymore. Consultants are not entitled to act in the best interests of the patient. They are required to act in accordance with the values and preferences that the patient has expressed over the course of their life. That is, what would the patient have wanted in these circumstances? Now, in many circumstances, the patient would have wanted to live. And it might be that simple. But it's not appropriate anymore to say we're acting in the patient's best interest as if that is a reason. The second comment that I want to make is in relation to clinical trial protocols. And there's a suggestion that you're only able to access this information, this drug, because the company sponsoring the clinical trial has included a double-blind randomized control process, including a placebo. And I think that that's accurate, but I'm not sure it's right. Compassionate care in many circumstances exists outside of clinical trial procedures. And if we need to take a stand and say we can't do this, but we'd like to participate in assistance, then maybe that's something that we should be doing, rather than bowing to what a multinational drug organisation requires.
Thank you. Speaking of the values and wishes of the patient, Miss Val Simpson, if we as the doctors and nurses looking after you didn't know which of 2 treatments were the best for you in ICU, would you be happy to be included in a trial comparing these treatments without your consent?
I wouldn't want to be in a trial if I was going to get a placebo, let me tell you that. 50% chance that it might work, I couldn't be bothered. I don't think, even to advanced medical knowledge. But yeah, I want you to do what you can to find out what's the best treatment, so go your hardest.
Okay, thank you. So I'll skip ahead a few of the questions in the interest of time. Judge Davis, those who promote vitamin C recommend it is administered 6 hourly for 7 days. Should the treating team get informed consent to continue vitamin C?
I got lost the first time they were proposing vitamin C on the basis that it seemed to be an instinctive act by somebody and not evidence-based medicine. So it's not research, this is just random medicine. I think that George Washington got. Somebody thought vitamin C might help, so we'll have a go. I'm not quite sure if you can improve that by getting consent later to something which is a sort of a nullity in the first place. So I don't think you could do anything to redeem it, because I think it's very flawed in the first place.
Mr. Ruschena, if the woman was initially admitted under a compulsory treatment order, can she participate in this trial?
Yes. Do you want me to explain why? Yes. There are procedures in the Medical Treatment Act and in the Mental Health Act that allow for a person who is the subject of an order under the Mental Health Act to participate in medical research trials. There are certain requirements that have to be obtained. The ordinary medical treatment decision maker, so mum, dad, son, daughter, brother, sister, don't get to make a decision. There is a discussion about whether or not the patient has the capacity. If the patient doesn't have the capacity, then an appointed person makes the decision, that is appointed by the patient at a previous time, or appointed by VCAT. And if those people don't exist or aren't available, then the authorised psychiatrist makes the decision.
Thank you. Okay, this is a little bit of a question about consent to continue. So if the patient is admitted not under a compulsory treatment order, just a normal patient, on Friday evening and included in the trial as emergency treatment, by Monday evening, the team trying to obtain consent has been unable to find time to speak with the treatment decision maker. If the treating team wish to continue the research intervention, at what time does the decision maker need to consent to continue participating? Like, how long do the doctors and nurses have to gain that consent to continue participation? What time frame?
Well, I think they just continue to have the ongoing ability. If the patient hasn't recovered capacity to consent themselves and they can't find somebody, then they'd have to either proceed on the basis that each successive intervention is part of the original intervention in terms of meeting section 53, and if it's not, then there may be a problem. But I'd like to think that it could be resolved by them just continuing to provide that engagement in the trial, because it's my view then that you'll be dropping people off every time you discover that they don't have a substitute decision maker, and that really is one of the obstacles to the participation of people who don't have those people to participate in the trials.
And Mr. Ruschena, if we are operating under a model of consent to continue participation from the treatment decision maker while the patient is incapacitated, should we also obtain consent from the patient once they have regained capacity to retain the data and keep the trial data?
There are two possible scenarios. The first possible scenario is that the protocol is still going on, in which case, yes, the patient's continued participation in a clinical trial is the subject of consent. The second possibility is that the protocol is finished and you're either continuing to monitor the patient or you are, or the patient's died, in which case you are asking for information, for the opportunity to retain the information. I'd say in circumstances where the patient's just continued to live, then the medical treatment decision maker's decision is acceptable, although I note that it's common practice to say if you wish to withdraw from participation in this trial, you can withdraw at any time and your medical records will be expunged from the record of the trial. So that's kind of overtaken by practice.
They have to be asked to consent, don't they? I mean, if the person recovers, you can't have a medical treatment decision maker overriding the expressed wishes of a person who's recovered capacity to consent or withdraw.
That's true.
Yeah,
I agree. The question is, what are they consenting to if the protocol's finished?
Oh, well, they can just say, I understand I was involved in a trial and now I've recovered and I don't need a medical treatment decision maker to make any ongoing decisions that emerge from the trial. If there are any, you can ask me. That's all it really means.
This is a splendid story. I didn't have a medical decision treatment maker, whatever you call them. I was in a ward, not in the ICU, but I was in a ward, and the doctors wanted to do a procedure, and I said, no, I don't want to have that. I don't see that it's important. And they said, we'll ring Pete. He'll let us do it. And I said, you just try. That sort of thing, consent. But I did get the nurse home and say, just give Pete a ring and tell him not to consent to anything today.
I like that story. So if the patient dies before consent to continue participation or retention of data is obtained, should the research team contact the next of kin or the decision maker post-mortem to obtain consent to retain data? Judge Davis.
I don't think so. If the patient gave their consent to participate in the trial, I think it covers the whole trial, including the collection of data. I don't see the need to go back and consult relatives. If, however, there was a medical treatment decision maker involved, once the patient dies, I'm not quite sure how they have any right to make any decisions about somebody who's died, because they're a substitute decision maker in the lifetime of that person, not after they die. So I think it's sort of, you just have to assume that it continues, that whatever consent was given continues for the life of the project. Otherwise it corrupts the data, doesn't it? It means you're dropping people off again ad hoc, randomly, and you're corrupting your pool, and there is no real reason to do that. No ethical reason why you have to do that if the patients die.
We've had situations like that come up on the ethics committee where someone has been enrolled in a trial, no consent was given, they've passed and their medical treatment decision makers were there, but obviously you don't want to get consent in those tragic circumstances. So they applied to HREC to waive consent to either continue to use the data, or if we don't agree to waive consent, then they remove the data from the trial. So it does go to the HREC committee to discuss. We've done that twice recently.
That there is no need to get that consent once the patient's deceased, and removing the data from the trial might not be the right thing to do. So it's... That's why they applied for the waiver. Yeah.
You cannot provide medical data without the appropriate procedures. There is a procedure in circumstances where a patient has died. It is that the consent is obtained from the senior available next of kin, as that person is defined in the Human Tissue Act. So unless consent has been obtained for the transfer of information, there is a breach of Section 141 of the Health Services Act, unless you get consent from the senior available next of kin. After the patient has died. And yes, the medical treatment decision maker and the senior available next of kin can be different people. And the senior available next of kin is not the executor. There are a wealth of disputes about this particular issue, and I carry the scars of those disputes.
There's been a constant talk about getting it afterwards, but one thing I've never heard is a time frame. Because is there a time frame after which you can't ask for consent? Say a person dies and you go to, and you then say, I've tried for 12 months to get their next of kin or something like that. What happens?
So it comes back to these points. Firstly, you cannot use the information. You cannot use the information without consent or approval. So unless you have the authority from ATREC, you can't use the information. But the ATREC has to have a lawful reason to authorise you to use the data. And use for medical research purposes, there's like 5 or 6 different requirements including the use of identifiable, whether or not it's possible to achieve the issue without providing identifiable information. So the question needs to be reversed, which is in what circumstances, or how long can you use the data without obtaining consent? And my answer is you can't. Does that help? No. I was being so clear in my own mind. You have to undertake what's reasonable in the circumstances. If you've followed your leads and they're gone, then they're gone. There's nothing more to do.
I love that word, reasonable. Okay, in the interest of time, because it's nearly 1 o'clock, I will take one more question from the audience, and that will be it. Thank you.
Thank you. I'll try and make it quick, even though it's a half-formed thought in my mind. So I'm a bioethicist and a research nurse over at Peter Mac. So my thinking around consent is very much more around the setting of oncology trials. So it's really interesting to hear you talking about consent in the emergency setting. And I'm finding it really uncomfortable thinking about notions of consent in this way where, we're talking a lot, I keep hearing people talk about informed consent, when in reality, this whole notion in the emergency setting is a complete fallacy. There is no such thing as informed consent in this setting. So I think my question to the panel really is, do we not need to really dispel of this whole notion of consent in relation to the emergency setting? Because we spend so much time in oncology thinking about whether when we consent our patients, whether what we're doing is really in line with their values and preferences, and we really wrestle with that. But in this setting, it just doesn't seem to be possible, especially given the fact that even in our setting, really, do patients understand a lot of the jargon and stuff that we throw at them? So do we really not need to think about whether in the emergency setting it is simply a special case and notions of consent should really be dispelled with if, as a society, we really value research enough and want to see progress, and so do our patients, clearly?
An excellent final question.
One of the things I enjoy is appearing in front of large groups of people and being the big bundle of no. Now, I acknowledge that your question is made in the best possible good faith and is made with the hope of advancing the care of your patients. So please understand my response is not to you, but to the argument that you're making. In the 20th century and before, we have had a large group of circumstances where people have said, this group of people cannot understand what it is that we are telling them, and we should be able to take that decision away from them. It's not necessary for us to go to the trouble of making sure that we can communicate with them in a way that they understand. It's impracticable. It's burdensome. And we found ourselves as a race in trouble because we failed to do that. I think that we should always be striving with people like Val's help to understand what the lay people can understand. And I think that they can usually understand quite a great deal more once we get rid of the superfluous detail. Let me give you an example. We had a patient. The patient suffered from a lifelong developmental disability. He had an IQ in the 70s to 80s on a neuropsychological assessment. And he was suspected of having bowel problems. And the question was asked, do we need to obtain informed consent from this individual to have him undergo the tests about whether or not he was actually had these bowel problems? And they were saying, well, he's got an IQ in the 70s to 80s. He's probably not going to give us informed consent. And I said, you're actually asking him a very simple question. Are you okay to have something stuck up you? If it's not stuck up you, there's a high likelihood you could die. That's the choice. Stripped of everything else, that's the choice. We don't know whether or not how likely you are, but that's the choice. I think once we get past a lot of the detail, we acknowledge that it's not actually relevant to the patient's decision and to the participant's decision. And we get caught up in the moment as a society. We've got to do this now. We've got to do this now. Can you help me out? When, firstly, we don't necessarily need to do it now. And secondly, we probably knew it was coming anyway, so we could have invested the time earlier.
You go into somebody's home, and the ambulance arrives, they've had a cardiac arrest. You've got to act. It's not like, oh, we'll think about it. Guys, we know, I think we'll just speak to the wife for a couple of minutes while the patient is down there and we think about it. You know, you can't do it. Now, we can say, therefore, because we can't do it realistically, because we want to administer the intervention immediately, therefore there must be no research in these patients. We will continue to bleed them, give them poultices, and scarify the back of their throat, and give them an enema, because that's the implication, right? At a higher level, of course, right? If that is the way we're going to interpret the act, when it says you're delivering an intervention with the intent to help the patient, because you cannot be sure that 100% of the time that specific intervention will be delivered, and that 50% of the time they'll just get usual care, then how is that different from what the hell you would do with usual care anyway? I mean, you either give them usual care, which you're going to give usual care anyway. The administration of placebo is irrelevant because you'll be giving them usual care, or you give them additional intervention which you believe is helpful to the patient. So you're either delivering an emergency intervention to save their life, which is usual care with CPR, intubation, oxygen, or you're delivering an intervention which is there to help the patient survive with a plus. So how on earth are you actually violating the act when under both circumstances you're delivering a treatment that is intended to save the person's life? And this kind of interpretation, legalistic or literal, to me, really is, and having listened to the parliamentarian, is a subversion of the intention of what was actually behind the act. It is disappointing that politicians don't actually preamble every law by saying, this is what we intend to achieve, because at least there will be a mission statement at the top that would allow us to interpret all these things. And the fact that different people, reasonable and different points of view, interpret these instructions in different ways tells you that there is no specific instruction that all and sundry would believe to be correct. And if there is no specific instruction that all and sundry would believe to be correct, how can anyone impose their individual will over that of a group or an ethics committee or a majority of people assembling together and making a decision about what is reasonable? Then it becomes a particular individual's interpretation of the world, blocking what the other 22 people would agree to. And I don't think that was the intention of the act.
Can I just say, I agree with that in principle, because an ethics committee is composed of all its members and it makes a decision as a group, and so reasonable minds can differ, and obviously a committee may decide something notwithstanding the fact that some people remain not happy with it, and they probably should be doing that on the best evidence available to them, which would be expert trialists explaining the basis on which they propose to proceed. The fact that Parliament has seen fit to legislate and allow for emergency research suggests an intention. The question is how, and the Declaration of Helsinki indicates that there's nothing wrong in principle with placebo. The question is how you make that fit into the provisions of Section 53. That is a testing question, but it's one that we shouldn't, I don't think, should just abandon. I think we have to try and make it work, and just requires a bit of work.
I'd like to thank our speakers. It's, as Judge Davis says, the more I hear, the less I realise that I know, but it's been enlightening. We'd like just put our hands together to thank them.